Always so glad to see new names. So welcome to those who are new with us today. And for those of you who don't know me, my name is Elena Dinkin, and I'm the director of the Senior Adult Programming here for the YMCA. Just want to share with you our upcoming programs for the rest of the week after today. Tomorrow, the Museum of Fine Arts Houston will be talking about the Marzio years at 1 p.m. and at 3:30, a small group member meeting where we're going to enjoy some brain games to challenge your mind. On December 3rd, we have Rob Landers in concert, who is a well-known pianist and organist, been playing over 25 years at St. Luke's United Methodist Church. So please join us for the upcoming programs. Today, it gives me great pleasure to work with UTHealth Neurosciences, and I ask Elise Pratt to introduce herself and to introduce our presenter for today. Thank you, Elise.
Hi there. So today we have two physicians to present, and I'll say a bit more about them, but we are UTHealth Neurosciences. We're the largest neuroscience provider in the region. We've got, I think it's 15 locations now, almost 150 providers. So really a lot of expertise and capabilities to help people with a variety of neurological and neurosurgical disorders. Today we've got Dr. Ashley Amsbaugh. She is a pain management specialist. She'll be presenting on spinal stenosis. And we've also got Dr. John Caridi. He's a neurosurgeon. Only thing is that he just got called into an emergency surgery. So he is hoping to make it back in time to do his part. So Dr. Amsbaugh is going to start, and then he'll take it from there, or she can take extra questions if he is held up in the OR for much longer. So I guess other than that, Elena already mentioned, put your questions in the chat and we'll get to those all at the end. And I'll also put contact info in the chat toward the end so that if there's any further questions or you want to find out more about us, you can always find out more there. So Dr. Amsbaugh, if you want, I will let you go ahead and start the show.
Hi, everyone. Good afternoon. Thank you for joining us so that we could go over these topics. As Elise mentioned, I'm going to be filling in for Dr. Caridi unless he's able to join us here in a bit. So we're going to be talking about spinal stenosis and what that is, and different treatments and things to look for. And please, as they both said, please write any questions you have down in the chat and we'll try and get to them as we can. Can't seem to get my screen to, oh, there we go. So here we have just a nice image of clearly the spine, how we are different from primate spine. Our spine has multiple natural curvatures. We have 25 different bones that make up the spine, 7 in the cervical or neck region, 12 in the thoracic or rib cage area, 5 in the lumbar or low back, and then of course the bottom would be the sacrum and the tailbone. As you can see, our spines are completely upright and we have natural curvatures that help us to keep our head over our hips and shoulders in alignment. Here's this image of how the bones sort of surround the anatomy of the spinal cord and how the nerves come out. You can see there are multiple different parts of the vertebra, and all of these have a specific way to align so that we are able to stand upright.
They're saying that they cannot see your screen. I'm wondering why not.
Uh-oh.
Let me see here.
I can see it, so maybe it's a sharing thing on your end, Elena.
That's what I'm trying to see. I'm so sorry for those of you.
It looks like some of them can see it.
Okay, now I think it should be. She needs to share a screen, please. I think it should be okay now.
Sorry, if you're not, technical difficulties.
I'm sorry. I apologize. I think it should be okay now, though.
Okay.
Okay, they can see now, yeah.
Okay, great. So okay. This is just the first slide I showed. I only did a couple. So just basically 4 parts of the spine that align to keep us standing upright as our normal anatomy. The spinal canal, where the spinal cord lives, is sort of indicated in this slide on these three images as these sort of diagonal lines. This is where the spinal cord lives, and it can have multiple different shapes that are normal, and that all is dependent upon this bony anatomy that surround it. So how does spinal stenosis or narrowing occur? This can occur from several different things. It can be related to disc dehydration. The discs are the shock absorbers that cushion the spine and the bones. It can also be related to different levels of arthritis around the bones that happen as we get older. We have bony growth, and that can impinge on the spinal cord and also the nerves that exit the spinal canal. Lots of people can be at risk for degenerative spine. It can happen with age and spinal stenosis, but definitely if we have curvature of the spine, also known as scoliosis, that can definitely cause spinal stenosis. This is an extreme image of scoliosis that you can see. This is clearly an S-type shape where you can see that all levels of the spine are affected. How do you know if you have stenosis? Well, you can have pain, you can have weakness, and typically these things can be alleviated in the lumbar stenosis region by flexing forward or bending or laying down or sitting. That can alleviate pressure off the nerves, and that might indicate that you have a stenosis problem. In the neck region or the cervical region, you might have numbness in your hands or difficulty with dexterity or using your hands for writing, doing fine motor skills, typing, holding dishes, things like that. Lots of things can mimic stenosis. You can have vascular conditions such as vascular disease, aneurysms in the vessels, musculoskeletal disease like osteoarthritis, neurological conditions and peripheral neuropathy that are related to diabetes and poor blood flow. You can have nerve entrapment like carpal tunnel if you use your hands a lot on the keyboard. Renal or kidney disorders can mimic this sometimes, and also even psychological disorders such as depression. So what may happen if you think you might have a spinal stenosis or you have any of those symptoms? You would visit your regular family doctor, your primary care doctor, and they might order various imaging studies, usually starting with x-rays, which we have here on this slide. This is a picture of the lumbar spine from the side view, where this arrow is indicating, that's pointing at the disc between the L4 and the L5 vertebra. It's narrowed compared to the levels above, these darker regions. And so I would anticipate that this person has some sort of stenosis in the spine based on the x-ray, which might lead to other imaging studies being ordered, such as the CT scan here. This, on the picture on the left, you can see this white area indicates the dye that is injected during a CT myelogram. Here in the middle, there's no white areas. That indicates it's not a continuous space and that there is some stenosis there. You may also look at an MRI picture, which this is a cervical neck MRI, and this white stuff is the fluid that surrounds the spinal cord. And you can see it's not continuous all the way from the top to the bottom. There's areas here that are very stenotic and being pinched off. So what can be done about spinal stenosis? Well, before there's ever a surgery or consideration of surgery, we really want people to try the most conservative treatments that they can do. So big part of that is physical therapy. We often prescribe physical therapy to be done in an outpatient setting where you can go and be evaluated for weakness, range of motion, and lots of things that physical therapy interventions can help with. And oftentimes people have significant improvement with their daily activities by just participating in physical therapy. And oftentimes your physical therapist will give you exercises that you can do at home so that you can modify your lifestyle based on exercises that they give you. Additionally, we can do interventional procedures, which is my particular specialty, where we look at the spine and we look to see what levels might have stenosis, and we try and do a procedure around that area, which I'll go over additionally later in the presentation. And then lastly, if none of these other things provide relief, we do consider surgical options. Well, as mentioned, this is a last resort. You would have previously what we call fail conservative measures, and your symptoms would need to be progressive, leading to weakness or even incontinence of your bowel and bladder. These are definitely reasons that you would need to have surgery. What does surgery entail? Well, it sort of depends on how extensive the stenosis is. Sometimes this can be done minimally invasive by a surgeon with small incision, doing the procedure with very small incision and very small amount of suturing that needs to be done, versus a very big open procedure where you have a very long scar and a very, with multiple levels of the vertebra needing to be removed and or decompressed. This might occur with decompression, which is where a surgeon will go in and remove part of a disc or part of the bone to create more space around the spine or the nerves to alleviate the pressure that's causing the symptoms. Sometimes, if the surgery is very extensive and they need to remove quite a bit of the bone, they will also need to do a fusion to keep the spine stable. Because as you can imagine, our spines all have a purpose with those curvatures that I showed on the very first slide. If you were to remove a large part of the bone in the posterior or the back of the spine, you would create some instability. So if that happens, we would need to put some hardware in there with rods and screws to restabilize the spine. So it's really important that if you had some of these symptoms and you wanted to be evaluated, you start by going to your regular doctor. These symptoms, again, would be pain with standing, pain with walking, numbness and tingling of the arms or legs, and of course, weakness or possibly changes in your bowel or bladder. So I'm going to talk a little bit more about the non-surgical treatments for stenosis that we offer here at UTHealth Neurosciences that may help you delay or avoid surgery altogether. So back pain, as you know, I think there have been several lectures through this platform is a very big topic, and there can be lots of different causes of back pain, including spinal stenosis. We already reviewed the anatomy, but this is just another good slide to show the side view of the spine with all the different cervical, thoracic, lumbar, and sacral segments. This picture on the right is like a cross section, if you were looking cut-wise, of how the bones surround the spinal cord as well as the disc here, as well as vessels. And these side things are how the nerves exit the spinal canal and go down the legs or the arms. So as I mentioned, if you were to be seen by your regular doctor, they're going to ask you multiple different questions about where the pain is. What can you describe the pain? Is it burning, sharp, dull, aching? Are there any other complaints such as weakness? What type of things have you done that make it better? Are you taking over-the-counter medications? Are you using ice? Are you resting? Are you stretching? And what makes it worse? Any type of specific activity, sitting, standing for long periods of time. Also really important that we get a good medical history. Do you have diabetes? Do you have heart disease? Do you have any cancer history? Also important, what type of surgeries you've had. Have you had a previous back or neck surgery? That would be really important for a pain management physician to know before doing any type of interventional procedure. What medications are you on? Are you on any blood thinners? That would definitely impact our treatment. Social history is, are you a smoker? Do you drink alcohol regularly? These things can impact our treatment. What allergies do you have? And do you have a family history of degenerative spine or spinal stenosis in your family? That can impact your treatment as well. Part of our exam would involve a neurological exam, looking at how the strength of your arms and legs. Do you have any change in sensation as to sharp or dull touch? How are you able to walk? Things like that. And this is another slide regarding all of the different testing we have to try and pinpoint the areas that you might be having issues in that we can address with an interventional type procedure. So in spinal stenosis, like we've said, there can be a lot of pressure on nerve roots, and that may be causing your symptoms. So if that's what we're looking for, we need to identify the level that we can try and alleviate with an interventional type procedure. So this is a nice little slide to demonstrate how I might think of your back pain based on the symptoms that you are describing. Radicular symptoms mean, is this pain that you're having in your back going down your arms or your legs? If yes, then you might be a candidate for an epidural steroid injection, which I will go over in a minute. Is the pain not going down the arm or legs? Is it just staying in the low back or the neck? That might indicate you have a facet dysfunction, which is basically arthritis of the joints in the back. If so, there are procedures called medial branch blocks that we can do. Or is that not the cause and you have stenosis problem? If so, that leads us back to trying an epidural steroid injection. And if not, if there's no stenosis on imaging, then are we just having disco pain, which may again lead to an epidural steroid injection, or other type of pain such as sacroiliac joint pain, which we won't really have time to discuss today, but is a big component of back pain. So here's, the pain medicine approach, an interventional procedure approach. We do epidural steroid injections, facet joint injections or blocks, and other types of procedures that we'll go over. An epidural steroid injection, I'm sure many of you have heard of having an epidural for women that are in labor. And an epidural just refers to the space in the back or in the neck where a lot of the nerves kind of traverse or go through that may have a lot of inflammation. This space is easily accessed by a trained physician with X-ray guidance to inject some medication around a nerve root, like indicated in this picture where it's red, to try and give a little bit of steroid medication to help alleviate the pain associated with inflammation from the nerve being compressed or having inflammatory markers from other causes. These procedures are really nice because they are minimally invasive and they're completely done as an outpatient. Oftentimes it's done in under 10 minutes in the office. We do use X-ray guidance for these procedures, so there's no guesswork, so to speak, on the target that we're looking for. You do not need to be asleep for these procedures. We do them awake in 99% of the people that come to our office. It's very quick. There's minimal pain associated with it. We do a lot of numbing of the skin where the injection would take place, and there's no downtime. When you go home, you're really doing your normal activities that same day. This is just some X-ray pictures that we'll see during the procedure. The picture on the left is a steroid injection at the L3 or the lumbar third level. You can see this dark part on the right-hand side. That is where the dye that we injected is spreading. That indicates where the injection will take place. This darker line that's coming out to the side is actually the needle that is being used. And then the picture on the right is the level below at the lumbar 4 level, where this dark medication, a dark spread of medication is indicated in the correct place. So this is the type of image that we would see during the procedure. The other type of injection that we do very regularly that help with lower back pain related to spinal stenosis is called lumbar medial branch or facet blocks. And this is a completely different procedure than the epidural injection. This is actually targeted at these small nerves indicated in red here on the image that can become very irritated and painful with arthritis of the spine. And so again, this procedure is minimally invasive, done as an outpatient. These procedures also do not require any sedation or downtime. This is an interesting procedure because it can be diagnostic in a way and also therapeutic in a way, meaning diagnostically, it might give us a good indication that when we do the injection, if you have relief, this is where a lot of the pain generator or the pain sources is from. Therapeutically, it can be treated with steroids, and that may give you a lot of relief for several weeks or even a couple months. If you had good relief with this type of procedure, it may be beneficial to go in later and do what we call a radiofrequency ablation, which is basically causing a small burn in these little nerves that may give you a much longer relief than we are able to achieve with just an injection. People that have a radiofrequency ablation can actually have relief up to 6 months and some people up to 2 years during afterward. So it's been very popular in many patients. This is just an X-ray showing what we might see during the medial branch blocks. This is being done on the right side. You see 3 needles here at the L4 vertebra, L5, and here right above this, the sacrum. And then this picture on the right is the same procedure on the left, just a slightly angled X-ray view. And you can see the needles here, 1, 2, and 3. This is a slide just kind of going over sacroiliac joint, where that is. Down here, you would feel pain in the buttock. This joint that kind of joins the sacrum or the bottom part of the spine to the hip bone here on the side can also have arthritis and a lot of inflammation associated with it that may cause pain in the back, lower back, and also sometimes down the leg, which is not related to spinal stenosis. And so we can do injections for that also, which here is an X-ray on the right-hand side that shows a small needle near that joint space. And then finally, some patients are candidates for spinal cord stimulation, which is a very involved topic that I think we would need to visit on another day, but essentially involves putting electrodes into the behind the spine, and it's connected to a battery that can provide pain relief for a specific set of patients. Pain and back pain is a very, very common problem. 80% of the population will have some type of low back pain during the course of their lifetime. That might occur acutely after lifting a very heavy box or moving a piece of furniture. And sometimes it becomes a chronic condition. Many of episodes of lower back pain will self-resolve over time. The World Health Organization has said that due to back pain, there is significant loss of work in the United States that can cause losses up to $100 to $200 billion a year in the workforce. So it's a really big, it's a big interest for the country. Chronic pain can affect Americans that have many other diseases such as diabetes, heart disease, and cancer combined. There is more chronic pain than all of that in our country. I appreciate your time today. This is me, Ashley Amsbaugh, and I'm seen in offices in the medical center and on some days in the Northeast office in the Humboldt area. And here's our contact information, and I will leave that slide up for anybody that needs to write that information down.
Great. Thank you so much. I know that Elise is going to help monitor questions now. So we have some great questions. Continue to put them in the chat box. What a great presentation. So thank you, Elise.
Yes, and thanks, Dr. Amsbaugh. We've got one question that I already know the answer to is, will a copy of the presentation be available? And Elena is going to take care of it for us. Elena, you'll be emailing out, I guess, information?
Yes, absolutely.
Okay, so I've been compiling the questions that have been coming in. Let's see. So some of these you might have touched on, but one of them is this inherited? And also, does this cause tension or aching in the thigh muscles?
So spinal stenosis, it's in and of itself is not a genetic condition, but factors leading to spinal stenosis, like degeneration of the spine, and that can have some genetic factors. Oftentimes you see, grandmother and mother and daughter all suffer from the same type of spinal curvature. And that leads us to believe a lot, there are genetic factors at play. And then Elise, what was the second part of that?
Does it cause tension or aching in the thigh muscles?
So it can definitely cause pain that goes into the legs, and whether or not that's aching and tension, it might just be dependent on how you perceive pain. I'd be more concerned if you had weakness or shooting pain and numbness and tingling down the legs.
Okay. Next one, is peripheral neuropathy a common symptom of spinal stenosis?
Yes, it can be. Peripheral neuropathy can have other causes such as diabetes or poor circulation or medication side effects from chemotherapy. But if you have pressure on the spine and the nerves that come from the spine, you can have peripheral neuropathy also.
Okay. Another one is, do you offer artificial disc replacement as an alternative to fusion for thinning discs?
So that would actually be a better question for Dr. Caridi. I can't speak to that. I know that, spacers have been tried with variable success rates, but I know that the mainstay of treatment for a disc is a fusion or partial removal of the disc.
We'll have to get him back on since he, I guess, is still in the OR, because there's another question about scoliosis. So we can definitely get with Elena and have him come back, because that's one of his areas of specialty. This one, you touched on both of these. So one is spinal cord stimulator. Does that help with stenosis? So I know you mentioned that. And another one is, what is the best therapy for spinal stenosis? So if you wanted to touch on those.
Okay, sure. So spinal cord stimulator, it will not fix a stenosis problem. It might help the pain and other pain symptoms related to stenosis. So if you had spinal stenosis and for various reasons you were not a good surgical candidate, or you just did not want to undergo surgery of any kind related to that treatment, then you might be a candidate for a spinal cord stimulator. Like I said, it's not going to fix the problem, but it might alleviate some of the pain associated with the stenosis. So that involves doing a trial first, and then if the trial is successful, then you might be considering a permanent implant. A trial is done as an outpatient. You come in, you have a procedure done where we put trial electrodes in, and you actually wear a little battery pack in a fanny pack type thing for 5 days. And then after the trial is done, you come back to the office and we simply remove the electrodes. And then we determine at that point if the trial was successful or not. Regarding non-surgical treatments or non-procedure treatments for spinal stenosis, really the best mainstays of treatment are physical therapy and continuing to stay active. You know, oftentimes I see patients that have unbelievable spinal stenosis on their imaging, but they have very little symptoms or complaints because they have been able to stay fit and active and doing physical therapy and home exercises that have kept them relatively pain-free despite pretty significant stenosis on their imaging.
Great. Okay. Here's one. Is there a relationship between Parkinson's and spinal stenosis?
No, I do not believe so. Parkinson's affects, you know, oftentimes the central nervous system, more in the brain, causing, you know, a movement disorder and mostly in patients, but that would be unrelated to stenosis problems of the spine.
Okay. Here are some detailed questions. What is the percent risk of dural puncture with your experience of doing epidural injection? And what is your protocol for management of post-dural puncture headache?
Oh, wow. That's a good question. So in my practice, I haven't had a dural puncture, maybe 1 out of every 400 epidurals. It's very minimal risk. And yes, so dural puncture, post-dural puncture headache, I didn't mention in my talk, but that is, I guess, a risk factor of doing epidural. That basically occurs when the needle that we are using actually goes slightly too deep and causes a nick in the dura, which is a tissue plane that protects the spinal fluid from coming into the epidural space. So if you were to puncture that, even with a small needle, you will cause a leak of fluid to come into the epidural space. It's not dangerous usually, however, it does cause a pretty significant headache. The headache is easily diagnosed by having a very pronounced frontal headache when you're sitting up, and then when you lay down, it goes away. And then when you sit up again, the headache comes back, and when you lay down, the headache is gone again. And that's very classic for a post-dural puncture headache. So oftentimes these post-dural puncture headaches are self-limited, meaning they get better on their own with time. Other things people try are taking caffeine, coffee, soda, also taking anti-inflammatories, staying hydrated, drinking lots of water, and giving it time. If that does not resolve on its own for a few days, it's very possible to do another procedure into the spine called a blood patch. A blood patch is simply where you take some blood from an IV, and then you re-inject it into the spine. It sounds kind of crazy, but by injecting someone's own blood into their spine, just even a little bit, can sort of patch up the hole that the needle caused in the dura. I feel like a physician asked that question.
It does not say. Let's see. There's a couple just about the injections. It doesn't say which type, but maybe the epidural. How often can you have the injections?
So that's a really good question. I probably could have included that on the slide. So the minimal amount of time, a minimal amount of injections we can get by with, the better. Anytime you can avoid getting an injection, the better, just from risks that can be associated with it. The reason for doing the injection involves putting in steroids. So steroid use has its own set of risk factors. With chronic steroid use, you can have weight gain, fluctuations of your blood pressure, changes in your blood sugar. You can have hormonal changes over time. So the least amount of steroid that we can give, the better. That being said, it depends on how much steroid dose your individual provider injects at any one time. With the amount that I use, I safely give 4 injections in a 12-month period for my patients. And so I don't like to do more than that. So that's the.
Okay. Let's see, there's another one about, well, one person asked, I'm having a mild procedure for stenosis next week. Is it safe? And that was asked toward the beginning. So hopefully the question was answered, but if you want to speak to that at all.
Sure. I don't know what the procedure is, but if it's an interventional pain procedure, very safe. And with hopefully when you get the steroids in the right place surrounding the nerve that's being irritated from the stenosis, you will have alleviation of your symptoms. If you're having a small surgery, that has its own set of risk factors and recovery time that I'm not really qualified to speak to.
Sure, definitely. And any of these that are about surgery, I'm going to set to the side, and then we'll try and do another event soon with a neurosurgeon. Another question though for you is, this is a 2-part question. Can central spinal stenosis lead to crossed wires in the nerve trunk such that confusion of nerve impulses in, say, excretory functions can occur? So the question is kind of, can the wires get crossed in the nerves?
So no, not from compression of the spinal cord. When you have compressed the spinal cord from stenosis, the nerve just really loses function over time, which is why when you start to have symptoms like bladder incontinence with urinary frequency or bowel incontinence, unable to control your bowel movements, that is a surgical emergency and you need to be evaluated. So it's not that the wires get crossed, so to speak, with a central nervous system. It's more like they would lose function the longer that there's compression.
Got it. And then the second part, are there any dietary do's or don'ts or natural supplements that may be therapeutic?
So, this is a big topic with variable results. I know that there is a lot of good data with taking turmeric capsules as a natural anti-inflammatory. So that would be something to consider, but I think you have to take a pretty good amount of those capsules to have a therapeutic effect. Anytime you take a supplement though, that's even over the counter, even if it's FDA approved to take, you need to be very careful with taking those with your prescription medications because they might have a lot of cross reactivity and you might cause harm by taking them along with your prescription medications. And that being said, if you are taking any supplements that you buy online or at the health food store or the grocery store, it's really important to list those medications every time you see your regular doctor so that they have a complete picture on what you're taking. I know from my patient population, when I do procedures, I have to make sure patients stop taking their fish oil, stop taking their vitamin E and various other supplements that can lead to an increased bleeding when we do procedures. Patients might think that they're very harmless because they're over the counter, but in reality, they can have side effects. But to answer the first part of that question, I don't think that there's any natural supplements that we can say help alleviate spinal stenosis. Exactly.
Okay. And just a couple more here. I think you already gave this in your presentation, but if you could just recap, what is the definition of stenosis?
So stenosis is a fancy word to say a narrowing around the spine. And that can occur in the central canal, like where the spinal cord lives, or it can be foraminal stenosis, or where the nerve from the spine is exiting the bone that goes out into the arms or to the legs. So stenosis is just a fancy way of saying narrowing.
Okay. And then we talked a bit about peripheral neuropathy. So this is asking, do you deal with neuropathy also? Are there other causes of neuropathy? If you could just talk about neuropathy a bit.
Yeah, peripheral neuropathy is, very debilitating for people. It causes burning, numbness, tingling, pins and needles sensation in the hands and the feet. And it can be caused by so many different things. The biggest thing we see is a lot of patients that have diabetes that's uncontrolled can have uncontrolled peripheral neuropathy symptoms also. So if somebody has diabetes, getting good control of their blood sugars for a long time might help alleviate those symptoms. If you have poor circulation, you can have peripheral neuropathy. So if you have, poor vascular disease in the feet and hands, that can cause peripheral neuropathy, in which case you might need to see a different type of surgeon that deals with the vessels. But I know that if you do have poor circulation, if you are very active and you do walking, even that can make a big improvement with peripheral vascular disease and neuropathy associated with that. Many medications or alcohol use and smoking can cause peripheral neuropathy symptoms. So limiting alcohol intake and limiting smoking can also improve those symptoms. But from a nerve standpoint, from the spine, you can have nerve compression that leads to peripheral neuropathy also. Our injections can help with that sometimes. And also, as we talked about before, spinal cord stimulation can help with all types of peripheral neuropathy symptoms.
Awesome. And one more, if stenosis is due to osteoarthritis, is it better to see a rheumatologist first to see if medication could treat it?
So it just depends on, sometimes it has to do where patients end up first, ends up being determined on availability, sadly. Sometimes it's very hard to get in to see a rheumatologist for whatever reason. So a lot of times they will come to our office first. For osteoarthritis, the best medications are usually just anti-inflammatories, whether that's over the counter or prescription strength, which we prescribe often. And so whether or not you start with rheumatology doesn't really matter. If you're going to end up needing a procedure, they will send you over to us. Many patients don't like to be on additional medications, and so they don't want to take them, so they want to try a procedure. It just really depends on the patient preference. And then rheumatoid arthritis is different than osteoarthritis, and I am not an expert in rheumatoid arthritis, but that can also have its own implications and treatments that can also cause spinal stenosis.
Good to know. And, I will say that is one great thing about our group is you and Dr. Caridi are in the same clinic seeing patients together. So, sometimes we get the question of, should I start with a surgeon? Should I start with a neurologist? Should I start with pain management? And our doctors work closely together to be able to route patients to the most conservative and appropriate treatment. So that's why we love to have y'all all there in the same place.
Yeah, it's very nice to work in the same office as our surgeons so that we can collaborate closely and efficiently. It saves a lot of time.
Yeah, for the patients too. It's great.
Mm-hmm.
Well, I apologize for any of those of you who had specific surgery questions. We will definitely try to get a surgery focused talk scheduled, but I think this was a great overview of spinal stenosis and the pain management treatments that are available. If you have any questions, you've got the info there on the screen, and I'll also put it in the chat. If you want to find out more about our group, make an appointment, just learn more about us, there's our website. So I don't know, Dr. Amsbaugh or Elena, anything else that y'all wanted to add?
I would like to add a couple of things. We had over 50 people originally on the call, and I know some have had to drop out. But I just want you who are still on the call to recognize the value of this. I think it's wonderful. First of all, Dr. Ashley Amsbaugh is just smiling the whole time. She's very pleasant. But not only that, what we're able to bring or learn from UTHealth Neurosciences is fabulous. They continue to offer us these wonderful medical presentations. So please, please, please continue to stay on. It's a valuable way for you to learn and to stay in good health during this situation. A reminder of our other programs tomorrow. The Museum of Fine Arts has a presentation at 1. We have a small group member meeting. at 3:30 just to get to chat with each other. And Thursday we have Rob Landis, who will be coming, who has been singing and writing songs for quite a number of years. That will be a big bestseller too. So again, thank you to UT Health Neurosciences. I'll be sending out the recording, and everybody have a great rest of the day. Thank you so much.
Thank you for having me.
Bye-bye now. Bye-bye.